And I am very excited to be able to introduce to you Jessika Groce. She is the Chief Human Resources Officer at Evergreen Health. She's going to be talking to us a lot about what we've heard over the last few days and how that impacts finances. Jessika, please come on up and take it away.
Oh, there's a bottle of water up here. All right, thank you so much for having me. As he said, my name is Jessika Groce. I am the Chief Human Resources Officer at Evergreen Health. And I don't know who's advancing slides for me or if I'm doing that. Remote on the podium. I do not see a remote on the podium. Isn't it fun running when everyone is staring at you? Thank you. All right, so I thought I would start by just introducing myself a little bit to you. I have been at Evergreen Health for 25 years, the last 4 years, actually tomorrow, in the Chief Human Resources Officer role. I have an MBA, a couple of HR certifications. Evergreen Health, if you're not familiar with us, is a small 2-hospital system. We have a hospital in Kirkland, one in Monroe. They're both public hospital districts. We've got primary care, specialty care, big home care hospice program. The coolest thing about Evergreen Health is that Ann Peterson works there, so I think some of you may know her. I get to work with her all the time. For some reason, she thought it would be better to be in Vegas celebrating her husband's birthday than here listening to me today, which I'm a little offended about, but I'll get over it. This picture here includes my husband, who also works in human resources. Both of us have been in HR for 30 years, so lots of riveting conversations around the dinner table, as you can imagine. He is currently an HR director at the City of Seattle. And then my son is a sophomore at Bothell High School, active in band and FBLA. He just got his Eagle Scout last year, which we're pretty proud of. Likes Dungeons and Dragons. If any of you were into that when you were growing up, very popular again now with the kids. And then my pugs, Ollie and Otis. So that's my family. All right. So this is what we're going to talk about today. I basically broke it into sort of 2 halves, sort of where have we been, what are we struggling with. I imagine everything I say today, you all are going to say, oh, we've experienced pretty much exactly the same thing, because I don't think we're too unique in that. They say misery loves company, so I don't know if we're supposed to feel better because of that. And then the second half is what do we do about it? So I'm hoping I can give you a few tips and tidbits. There is not going to be one silver bullet, as we all know, so this is, what are the many things that you can do that all of them could help a little bit. When the leaders of this conference reached out to me and said, would you do a presentation on the finance of HR? My first thought was, what could I possibly say to a bunch of healthcare finance people? Because you all know this way better than I do. My budget is 100% expense and 0% revenue. You know that, right? Like, I don't think this is a model we want to expand. But when I really got into it, you can see under the sort of sub-bullets there's actually a lot, I think, that we can talk about. So I'm hoping that we'll cover a lot that's interesting, and I will leave some time at the end for questions if there's any questions. You have the session description and the learning objectives in your packet, so hopefully we will cover those. All right, I'm going to start with the favorite one of labor expense. Wages and benefits, usually the largest single expense in healthcare. According to ChatGPT, this is very official, often accounts for 50 to 70% of total operating costs. At Evergreen Health, I will tell you, we are above 70% now. So this is a huge expense in our organization. It has outpaced inflation, and because of the labor expense and a number of other things, right? Our industry is so unique because the patient census and volume do not always equate to higher margins, right? This is, if you own a store and you sell more product, you make more money. In healthcare, during COVID, there were times when our hospital was breaking the patient census record every single day, day after day, and we were just losing money. And our staff don't even get it. The clinical staff, they're like, how come I'm working so much and we have patients just waiting and people complain that they can't get into the clinics and we have no margin? This makes no sense, but this is the situation that we're in. So it's a very unique industry, I think, compared to other industries. One of the biggest factors that I, in my role, focus on a lot is turnover. So you can see in 2023, according to the benchmark that we look at, which is NSI, 17.2%, this is full-time, part-time people, turned over on average in healthcare, and in 2024, 15.4. So trending down, but still really high. This is, for me, a critical issue. This impacts our patients, it impacts our staff, it impacts our finances, right? Turnover, obviously, everybody knows, is not just the cost of replacing an additional staff person. It's the incentive pay that you have to pay somebody to cover. It's the overtime. It's bringing in a traveler or training somebody new. It's the impact on the staff when you're working in a department and somebody leaves that you like, and you're sad that they go, and then somebody new starts, and you spend a bunch of your extra time training them, and then they leave, and you're sad that they go, and so it's really also impactful to the long-term people who stay and stick it out. You lose the institutional knowledge, right? We had significant turnover in nurses, in MAs, and what we call PSRs, the patient service rep at the front desk in the clinics, imaging, especially in 2021 to 23. So this is what our turnover looked like. This might look familiar to some of you. You can see in 2019, pre-COVID, right, we bounced around about 13 to 14%. That's where our turnover for full-time, part-time people was at that time. This is our, excludes our Monroe Hospital, but the rest of our organization. In 2020, when COVID hit, our turnover actually went down a little bit because people kind of just hunkered down to see what was going to happen. They put their retirements on hold. They didn't do job searches, right? Everybody switched to working from home and all that was going on. People started baking sourdough bread and whatever. So they weren't looking for jobs. In 2021, where you see that red arrow, we had a major labor crisis. I've been at Evergreen 25 years. I've never seen anything like this, right? 2021 and 2022, we were just in survival mode. It was pretty scary, I would say. We have been able to maintain good patient quality during that time. All of our metrics have been good, so I'm not saying we put patients in danger or anything like that, but it was scary. In our administrative conversations, you could tell that people were very worried about it. This was not anything we'd ever encountered before. In 23 and 24, it kind of stabilized. Our turnover now is back down to about pre-COVID levels, but it took 4 years. You know, I don't know about you all, but when COVID hit, I was like, this is a blip. Our school district was one of the first school districts locally that shut down, and I thought, our superintendent is crazy. They're going to stop school? Like, what is happening here? And so I did not, every year, we do our forecasting, right? And every year, I'm like, oh, the turnover is going to return to normal this year. You know, the wage increases are going to return to normal this year, and our traveler rates are going to return to normal this year. But it took 4 years. And so every year, I have been wrong until about now. Our turnover in March of 2025 is 12.3. So we are back to where we were. It feels much better. But it was very concerning. The other thing that was really concerning about it is the turnover reasons. We always look at why people are leaving, right? The turnover reasons sort of during that peak were people being dissatisfied with the pay, people being dissatisfied with the job, people going to find other jobs. Now the turnover that we have is more people retiring, family reasons, health, school. You know, you're never going to have zero turnover, but we would much rather see those kinds of turnover reasons than people leaving because the work is too challenging and they're burnt out and they're worried about workplace violence and all those things. And we were experiencing that for sure. This is our vacancy rate. So the last one was turnover rate. This is vacancy rate. It looks almost exactly the same, right, as far as the trend. They mimic each other. Our vacancy now is under 5%. So very similar there. So labor shortages were huge, still are in some positions. It's much greater than turnover, as you know. I put the little cup there because I always think of it as sort of at least 3 factors, right? If the cup continues to get larger, meaning there's more demand for healthcare specialized staff, and the water or whatever beverage you want to imagine in that cup is seeping out, right? We've got more people leaving the industry and not continuing in healthcare specialty. And there's only a trickle pouring in because we have less people going into it. When you add all 3 of those things, it's sort of exponential, creates this labor shortage. And I think that's what we're experiencing. Our population's aging. Our hospitals are very full for the most part. There's a lot of demand for healthcare professionals. A lot of people retired or left healthcare during the pandemic. We had staff that were just like, I can't do this anymore, you know? We also implemented Epic, which I'll talk about later, in the middle of the pandemic, and we had staff that were like, I'm not learning this whole new system. This changes my whole world. I'm out of here. So we've had people leave the workforce. We've had people leave the organization. The Association of American Medical Colleges projects a shortage of 20,200 to 40,400 physicians only in primary care, that one specialty, by 2036. The International Center on Nurse Migration says that we could have a 4.7 million nurse shortage by 2030, which is right around the corner. So this is pretty real. We've seen a major reduction in healthcare school enrollments. I don't know if that's because youth don't see healthcare careers as an area of interest. I know anecdotally, I've got a high schooler, as you know. A lot of students are looking for high-tech careers, and I think they don't see healthcare as high-tech, even though I think there's a lot of tech in healthcare, especially in certain specialties. We have a tuition reimbursement program where we will pay our employees to reimburse our employees to go to school, right? A lot of places have programs like that, and we have seen a sharp decrease in our employees who are going back to school. So we talked to some of the local schools to find out if it was just us, and they all confirmed that their MA programs, RN programs, CNA programs, seeing a sharp decline in enrollment. So this is very worrisome. I think it's something we all need to look at, and I would love for us as an industry to figure out a way to get in front of those students younger, you know, and really sell healthcare careers and the variety. There's so many different things that you can do in healthcare, and many of them are high tech and cutting edge and research and really interesting. And so I hope that we can do that kind of all together moving forward. All right, so we have this huge labor shortage. What do? We turn to travelers, right? Our traveler rates went way up, kind of like that chart that we looked at, right? It almost mimics that. Actually, I think I have that chart. There you go, look at that. It looks exactly like our turnover and our vacancy rate, right? This is our traveler expense by month from the beginning of 19 to about now. And not only did we see an increase in travelers, but the dollar rate, the hourly rate for these travelers went way up, right? We all experienced that. And we started using travelers in specialties we have never used before. So we've always used some travelers. Travelers have their purpose, right? We used to mostly only use RN travelers. And we expanded during COVID to pretty much every single one of our imaging modalities, started using travelers. Anesthesia techs, sterile processing techs, pharm techs, surge techs, respiratory, social work, PT, OT, speech. We even started using travelers in some CNA areas, phlebotomists, MAs, coders. I mean, these are positions we never would have considered using travelers for before, and we just didn't have staff to do the work and felt like we had to do that. So at this point, things have stabilized, much like our turnover and our vacancy rate, and the travelers are way down. The number of travelers, the dollar rates for the travelers and the specialties we're using them in have all kind of stabilized a bit. But we're still using travelers in some areas we didn't before. Our imaging is really still a struggle for us. I'll talk about union negotiations in a bit, but we have many unions at Evergreen, and when we are in negotiations, a lot of times we start to feel the pinch for recruitment and retention because our wages have started to fall behind. There's sometimes some unrest a little bit while we're in the negotiation process. But then as soon as we finish that contract and we get it ratified and we put those increases into effect, we see an improvement. And for our imaging union contract, the last time we finished with them, we really didn't see that improvement. It's been a challenge still ongoing for a couple of years, so I don't know if we're alone in that. The other thing that was really tough about travelers during that time, I think, was that the permanent staff make less than the travelers, and everybody knows that, right? So we had a lot of complaint from our staff. You know, they'd say, on the one hand, we don't have enough staff, we need more staff to help us care for these patients. And then out of the same breath, they'd say, you know, it's not fair that the travelers are making more money and we're the ones who know this organization, are committed, have stayed here, are, you know, training them, and they make more money than we do. And some places even got to the point where they started hiring local travelers. So one of the ways I think we've kind of justified travelers is they come from somewhere else in the country, they're only here for 3 months, right? And we started hiring people who lived here, who left probably one of your hospitals and came worked at mine, or vice versa, as a traveler and made more money. And that was really, really upsetting for our current staff. So there was some employee engagement, morale, I think, impacts too with this whole traveler thing. We were able to convert a few of our travelers back to permanent, you know, staff. Not I'm not saying that we had local people who went to traveler and came back to us. I'm just saying that people who'd been travelers, they get an opportunity to work all over the country and try out different hospitals, and it can be an opportunity if you have a good culture and they like your work environment. Sometimes you can convince them to stay on permanent. So we have kind of a process where we make sure that HR gets in front of all of our travelers and we talk to them, and we've had a fair success converting people to regular employment. The MSP agreement that we have with the agency that provides most of our travelers to us says that there's no fee if someone has done 2 consecutive, like 13-week traveler assignments. So if they've been with us for basically 6 months, then we can convert them at no fee, which is nice. We had people that left us to become travelers during this time, and that was also very new to us. We hadn't really experienced that before. So there's our traveler expense. It is similar to the turnover and the vacancy rate grid that we looked at. The difference here is that we are seeing kind of an uptick again in 2024. You'll see, not obviously to where we were in 22, 23, but it is trending up for us. I don't know about the rest of you, but the Washington state staffing laws have been really challenging because we agreed on a staffing plan in our hospital staffing committee with our unions and our staff. And now in order to meet that staffing plan, we have had to increase some positions. And so while we're trying to get those positions filled, we've got a few more travelers. And so it's not like it was a few years ago, but we are definitely feeling a little bit of that cycle feels familiar to us. Wage competition, I don't have much to say about this one. This one's pretty obvious, but you've got the highly specialized healthcare staff, right? And you've got labor shortages. You combine those 2 things together, you're going to end up with increased wage competition. I really feel like we all know this is important, but it's such a balance. There's sort of that lead lag that happens in the community, especially when we've got union contracts, right, renewing. And we've had, for example, a local hospital that put out press releases during the pandemic that they were going to lead the market. And you know, what happens is then everybody else hears about that from their staff and from their unions and feels like they need to rise up and meet that, and so the whole market goes up. And so, you know, I think we've all been caught in that. What do we do when we're not up to market, and do we want to try and lead the market for a period of time? It's always a challenge. totally exacerbated, I would say, by the pandemic. And this, again, I said, was difficult to forecast. If it was up to me, our forecasts at Evergreen Health would have been terrible. So I'm glad that you all are in your roles that you're in, because my finance team was much better at forecasting what our wage increases would be during this time than I have been, because I am an eternal optimist and clearly did not think that we would be giving the types of increases that we have been giving for the last several years. We keep communicating to our employees. When we do, we call it the general increase that the non-union employees get. We're pleased, once again, to provide a higher than historical general increase, because I don't want these staff to forget that we used to give them a 2 or a 3% increase a year. People were very pleased with that, and that's not what we've given the last several years. So it's just a weird time. Union negotiations are a factor. I know we're very heavily unionized in Washington State, most of the state, especially the clinical staff and the support staff, right? Union collective bargaining, I think, serves a purpose, and we've got pretty good relationships with our unions at Evergreen Health, but it certainly can drive up wages and benefits if they're good at what they're doing. I talked about the lead lag. That really is, I think, increased when you have union contracts that renew every 3 years or whatever. There are quite a few practices, I would say, under the union contracts that are changing now, and I think it's important for us to all be aware of that. There have been practices in place in the region, in the state, in the nation, really, for decades that are changing now, and they're very expensive. So for example, we've had language in all of our union contracts. We've got 5 union contracts in Kirkland and 4 in Monroe. And we've had language in the contract that in order to receive a step increase, you must work 1 year worth of time and a certain number of hours. And it used to be full-time hours, and then it decreased to a lesser than full-time hours. Now the unions are saying practices like this are penalizing people who do not work full-time, who take leaves of absence, right? Mostly women, people caring for children. And these practices are outdated and they need to change, and they are changing in the market. So in our most recent round of negotiations with our nurses, for example, we spent a lot of time talking about this, and we are changing it. They would have liked for us to make all of these changes the very beginning of the contract. We could not afford to do that. We're spreading it out over the term of our contract, but if you haven't had recent negotiations with your unions, you can anticipate that all of these things will come up, but they will push very hard on them, and the market is moving this way. So I think we're all going to have to do this to remain competitive. Ghost steps is another thing. In the union contract, there are steps, right? They get step increases, and there are certain steps historically. I don't know how this started. I've been doing this for 25 years, but I don't remember how it started. It was in place before I started at Evergreen. There are steps where you have to work 2 or 3 years to go to the next step. So we call them ghost steps. You know, it looks like you move, but you don't really get an increase. They are eliminating those. What a lot of places are doing is taking, if an increase was a 4% step increase after 2 years, they're splitting them and making it 2% every year so that everyone moves up every year. They don't have to work a certain number of hours anymore. There's no more ghost steps. Every year they get an increase, but it might be a smaller percentage. And that's one way that organizations are doing that so that they can handle the cost of it. The other thing that we heard a lot about in our negotiations this time was flat amounts. So if you give a flat amount across the board, right, like $1, $2, that has more of an impact percentage-wise to those who are earlier in the range, those at the beginning of the range. And so in order to recruit new grads, in order to entice younger staff, different generations, some places are doing a flat amount and then a percentage increase. And that's, I think, going to change the market over time. We'll see if certain ranges become more competitive at the bottom. What we found is if we didn't do a flat amount, we would have been pretty far behind at the bottom of our range, but almost over the market at the top of the range. And so the union is the one that proposed the flat amount. We eventually agreed to it because when we looked at the data, we felt like it was actually a good thing for the organization and the employees. So all of these things are changing. I think we're all going to hear about them. You can expect them. They're very expensive. But I don't think we can sort of put our heads in the sand and ignore it, because I don't think we're going to get away from doing this in probably all of our contracts over time. One of the things that I always say about union negotiations is that the best strategy in negotiating is patience. In my experience, I've done this many, many times now, the union starts with proposals that are really high, that the organization could not possibly do, and the organization starts lower than what they're really willing to offer, right? I wish we could just say, this is what I'm really willing to offer, can we just get it done? But no, it doesn't work that way. Our nurses' negotiations took 16 sessions this last time. It was a lot of time. And we negotiate back and forth, we inch closer, and then there's this period of time where there's just a lull, and nothing happens. You meet and you talk, and you don't really make any progress, and no additional language gets agreed to, and it just feels like we're never going to get this done. What's happening? And then the union kind of has a playbook that they follow. For us, it's yard signs in the yards around the hospital, and they put ads in the paper. Sometimes they'll publish the CEO's salary. They do petitions and present things to the administrative team and come to the board. We have a public board because we're public hospital districts. And then, after they've kind of gone through this process, all of a sudden, towards the end, they will drop a lot of things that they've held on to at the table, and we will reach agreement. And so if you can be patient until you get to that point, you will reach an agreement that you can live with, that's good for your nurses and your staff and your patients. But you really have to be patient, and it's hard for people because it's not an effective, efficient process. If you've ever been in union negotiations, you feel like, wow, I really wish that I hadn't just spent an entire day accomplishing nothing. But if you want to be patient and have that strategy, you have to endure that time period where you are below market, and it will impact your recruitment and retention, and you can only endure that for so long. And so my CNO and I have had lots of conversations, because she said, I'm getting to the point where we have to get this done. We just have to agree to what they're asking for. We can't survive any longer. And I always push for the patients, but I understand she also needs to staff and take care of our patients, other kind of patients. So. And then the union will push for retro if you take a long time in negotiations and get it done after the contract expired, which we can do as a public hospital district. And then some of you are subject to strikes. As a public hospital district, there are a lot of things that are challenging about being a public hospital district, like the Public Records Act and all of that. But one good thing is that our employees cannot strike. It is illegal for public employees to strike. And so they can informational picket, where they go out during their breaks and before their shift, after their shift, on their days off, but they cannot do an actual strike. Strikes obviously can have significant impacts on patient care and reputation and expenses, and some of you probably have a lot more knowledge about that than I do. All right. Benefits expenses, we've seen a really significant increase in our utilization. Healthcare employees tend to be high utilizers of benefits anyways, because they're knowledgeable and they have the access, right? Compared to some other industries. But we've really seen an uptick in that in the last 2-3 years. We're self-employed, so we pay our claims and are very familiar with what our employee utilization is. But we've also seen a really high increase in high cost claims. Lots of pediatric claims for our dependents, lots of oncology. So, it's tough because these are employees who are utilizing the benefits that they are entitled to, and that's what benefits are supposed to be for, but the cost is just outrageous. And so we're seeing these huge renewal cost increases come by every year. And then the biggest one for us is the increase in pharmacy costs. From 23 to 24, we experienced a 20.9% increase, so 21% increase in plan paid per member per month. 20.9. If you remove GLP-1s, just that one class of medications for diabetes and weight loss out of there, the increase that we saw was 1.1%. So 20% of, 21% was the GLP-1s. And we have a weight loss clinic, so we're able to say you can only get GLP-1s for weight loss if you go through our weight loss clinic. It gives us an ability to manage it. But even with that, the cost increase is just so expensive. And I have heard, I'm not a pharmacist or a clinician of any kind, but they may be expanding the indications for GLP-1s to include sleep apnea, prevention of a second heart attack or stroke, and substance use disorder. So our benefits broker has said this could be an additional 20% increase in GLP-1 cost if they expand the reasons that you can use these medications for those additional diagnosis. And you know, the GLP-1s, I think a lot of people think they're great medications. They really work. They're popular. The doctors are prescribing them. That's why we're seeing this increase, but they're so expensive. So I'm sure this is something that you all are working on as well. We actually added what we call a pharmacy directorship to our benefit broker agreement. So our benefits broker, we added a pharmacist on their team. And anything that we talk about with pharmacy, we include that person. We include our pharmacy leaders who have been really great partners with us to try and talk all this stuff through, because it's very concerning. Okay, so that's the first half, which is where we have been and what we have struggled with. I don't know if any of that sounded familiar to you, but that's what I have been living for the last about 5 years. So the second half is, what do we do about it, right? And I do not have any strategies that are going to probably shock you or blow your mind, but I'm hoping that maybe there's a few little nuggets in here that you could take away. I think the best way to approach this is to do a few things that you can for recruitment, do a few things that you can for retention, look at your workload efficiencies, look at your employee engagement, and make small changes to all of those things to try and balance out all of this stuff that we're dealing with. So for recruitment, I'm not going to talk about all of these, just a few. The first one says employment value proposition. If you've never heard of an EVP, sometimes they call it an employee value proposition, same thing. It's basically a statement that you can use for recruitment marketing, that kind of thing, that sums up what is the value to employees if they work for your organization. And so we had a vendor, some of you might be familiar with them, Protiviti, that we actually use for our internal audit. And every year we do what we call an enterprise risk assessment, where we look at what are the big risks to the organization in any area, right? Cybersecurity and that kind of thing, earthquakes. And during this time, when our turnover and vacancy rate looked like that, recruitment and retention was way up at the top of the list. And so Protiviti said, we can't really do an audit for you on recruitment and retention. There's nothing out of compliance with your recruitment and retention policies, but we could do an assessment for you, right? We could look at your practices and see if there's anything that we would recommend that you do. And so we actually hired them to do that. And they gave us a couple of great ideas. The first two on this list came from them. One was the EVP. So for the EVP, you cannot say, we are a best place to work. We have competitive pay and benefits, because everybody says that, right? You have to say, what are the things that are unique to your organization that are different? I don't have our EVP memorized, but at Evergreen Health, we are very collaborative, relational. You have to be willing to pull groups together and have meetings and talk to people about stuff if you want to do anything. If you do not like that environment, you're not going to survive at Evergreen Health. If you like it, you're going to thrive. We have a very physician sort of focused leadership and decision making. So we've got physicians involved in every major decision. They've got dyads, right, where there's a physician with every operations person. And so there's just certain things that exist in organizations that are different than other organizations. We consider ourselves to be independent. We are a system technically, because we have Kirkland and Monroe, but very small system. We don't have a corporate or anything like that. So being independent, collaborative organization that values physician decision making and input, that kind of thing, right? So we thought that was valuable to have one. Many of you may have an EVP. We did not have one. We hadn't taken the time to do that, so we did that. The second one there, career website recruitment videos, we partnered with a company that Protiviti actually connected us with. They're called Largely, and they helped us create a database of employee videos. They're not highly produced, bring in a professional, do a video with a pretty background. We actually did one of those fairly recently, Evergreen Health, and the guy behind the camera sends over his assistant and says, can you smooth down her hair? So I'm standing there, and she's like gently touching, and he's like, no, it's not work. Like, run your fingers through it. So I'm standing there like, if you're gonna expect me to have perfect hair, then you should give me a hair and makeup person, because there's nothing I can do about this. I'm sorry. So these videos, though, through Largely are like selfie mode shot. People usually shoot them on their cell phones. It's staff saying, what do they like about working at Evergreen Health? What do their teams do as traditions? Who's the funniest person on their team? What was the last team building thing they did? You don't ask staff, please recite our mission, vision, and values, or something that they can get wrong, right? Or feel pressured about. You just ask them to talk about their experience, and then we put those videos on our job postings. So if you go look at job listings throughout the region, most of them look exactly the same, right? It's just a block of text, and it says what the pay is and what the benefits are and what the job requires. And now we've got videos that pop up and just run of our employees just talking about what it's like to work at Evergreen. And so we're just trying to do anything we can to sort of differentiate, right, the experience that might encourage somebody to apply for a job and be a good fit at the organization and continue. We've really returned to in-person on-site career fairs. They stopped for a long time. I thought they might go away forever, but we're really seeing that those are back and people are liking that again. We do same-day job offers for certain positions. You just have to move so fast to be competitive. Like most places, we do sign-on bonuses, reload, that kind of thing. We did increase our sign-on bonus amounts pretty significantly during the pandemic, kind of at the peak of the staffing crisis, and then we have reduced them back down. Some of them we've dropped off and we're not doing again. So that's a nice one that you can sort of adapt, like incentive pay based on the need. We did kick off international nurse recruitment during the sort of the height of the staffing also. And then the bottom one there, our COO started I think he started right before COVID, actually, because we always tease him that he started, and then he was the administrator on call, 2 weeks in when COVID hit, incident commander. So one of the things that he said was, when we had an executive position open, let's try and fill it internally before we go to a recruitment firm. So, okay, let's try it. So we posted that position, we got some candidates, we screened them, we got someone great, we hired them. We haven't used an external recruitment firm for 5 years, and we've had a couple of positions come open. Anne's boss, Bill Howe, our CFO, just started in August. He came from Michigan. We didn't use a firm, and he's incredible. And so this is really something that we've now taken on. We always try and recruit by our internal team first, and if they're successful, that's great. If they're not, we'll still use a firm, but we're not going to go straight to a firm right away. And those firms, they can put a dozen people on your position and cold call people, and they certainly have resources that the internal HR teams usually don't have. But I think it's worth, if you're willing to take the time, to do an internal process first. Not internal as in only internal people can apply, but using your internal HR team and see what you get. So I don't have a bullet on here for it, but we started hiring MARs in our clinics during this time. We used to only hire the certified, state or national certified MAs, and we expanded to MARs, which are lower scope, so they cannot do all of the same things that a state or national certified MA can do, but it opened up our pool, and we actually filled a lot of MA positions that way and have now adapted to what they can do and not do, and so that's something to look at too if you haven't done that. All right, retention. Obviously, competitive wages and benefits are probably the number one thing for retention, but there's a lot that you can do other than that. We really have focused a lot in the last few years on engagement, on employee wellness, and on safety. We hear a lot about burnout, about workplace violence concerns, about mental health concerns. And so we've been trying to provide some support and resources to our employees for those things. We have a lot of great employee committees. I told you we're all about the collaboration and relationships at Evergreen, so you can imagine we have lots and lots of meetings and lots of committees. And so our DEIA committee, our employee engagement committee, employee wellness, workplace violence prevention have been super active to give us thoughts and ideas on things that we can do in these areas. And it's not all things that cost money. Our employee engagement committee, for example, we relaunched an employee engagement or employee recognition program that had stopped during COVID, very low cost, very high enthusiasm about that from our employees. They did a walking campaign where they got people, to form a team and count their steps for a period of time. And we did it gold, silver, bronze because it was during the Olympics, and did trivia about the Olympics and, little things sometimes that we may not have time to come up with the idea to make it happen, but if you get a group of employees together and you give them some autonomy to work on it, they'll come up with things, and it's really been great. So we created an employee financial assistance fund during COVID that we did not have before, so employees who have really significant kind of unexpected financial hardship can get support. We added mentor nurses. There are nurses that don't have a patient load, and they are specifically to support our new nurses. So in some of our really big nursing departments that have a lot of brand new nurses, residents, people who've just cross-trained to that specialty, people who have 2-3 years of experience when they come in, now they have these mentor nurses that they can go to, and it keeps them busy all day just answering questions and being a support, especially on the night shift when there's not necessarily management there, that kind of thing. So those are kind of some of the retention things that we've looked at. Workforce development, I just mentioned, we have an RN residency program. New to specialty is a nursing program also for nurses who have been working as nurses but want to change specialty. It's a little bit less than the RN residency program, but designed specifically for that group of employees. Charge nurse and mentor classes, leadership development programs. I think partnerships with the local schools, as I said earlier, is really important. We need to get in front of the high schools and the colleges to talk about healthcare careers, and then we need to partner with the local healthcare programs to try and be creative about the way that we do this. Obviously, most of us do clinical placements, internships, that kind of thing. There's also the Hospital Employee Education and Training HEAT grants where you can, especially if you have a union, a lot of times it's a union, a hospital, and a education provider will put in a grant together request, and then we've done programs where our employees stay on the campus, the instructors from the college come to them, we provided them laptops, we provided them childcare, we provided them transportation. It's a wraparound where you try to avoid all of the barriers that would prevent them from going to school, and they're often environmental services, food and nutrition, roles like that stay in the organization and promote up into other clinical specialty roles, or CNAs and HUCs and PSRs that become RNs, that kind of thing. So these are great internal promotion programs. And when you promote someone with support in an organization, they will often stay with you and be very loyal to your organization. A local hospital partnered with a school in our area to provide CNA training, and they set it up where the employees could work, not as a CNA, because they weren't licensed as a CNA yet, but in a role at the hospital, getting paid, and 24 hours of time they would go to the local school and also get paid by the hospital for that. So they were getting full-time pay, working part-time at the hospital, and going to school part-time. It's kind of creative. It's a great partnership with the school. It's a way to get our enrollments up in the local area. And then those employees, I think, committed to taking a role at the hospital once they became a CNA and staying for a period of time. So lots of creative ways, I think, that we can all work on this one together. All right, last topic, workload reductions, efficiencies. So I said we went live with Epic in October 2022. You can imagine from the chart what I was feeling in October of 2022. And then we went live with Epic. And we didn't go live with Epic, in one small area, or we went live with Epic in both of our hospitals, all of our, clinics on the same day in October of 2022, with all functionality and all specialties. So it was a huge rollout, and we did it in way too short of a time, because by the time we decided that we were going to do it, we were on a time crunch. So it was kind of brutal. We heard a lot of complaints about it from our staff, who were already very stressed at that time, as you can imagine. But it has been really a positive since then. We've kind of, takes a while to get used to it. 93% of our patients now in the medical group are on my chart, which is a very high percentage. We're really proud of that. That was something that we made a leadership goal. It was something everybody worked on, our PSRs, our schedulers, the physicians, right? Outbound calls, all of our communications on our website and all that have encouraged people to do it. They don't have to do it, obviously, but it's been really great. And then through the MyChart, they can do self-scheduling. We've got that available in pretty much all of our primary care and a lot of our specialty now, which Epic says their national benchmark number is that every appointment scheduled via self-scheduling saves the organization $7. So for us, that equates to about $875,000 a year. It's a lot. And that's due to the savings in staff time and improved no-show rates. So it's funny, I don't know about you, but if you call a clinic and you want to make an appointment, first of all, you might have to wait on hold. You finally get through, and they say, can you do it on this date at this time? And you look at your calendar and you're thinking, I can't do that. You say, I'm so sorry, I can't do that. Can you do it on this date at this time? Oh, I'm sorry, I can't do that. And then they say, can you do it at this time on this date? And you say, yeah, okay, I can make that work. Even though you're thinking in your head, oh my gosh, that's going to be a huge hassle. I don't know if I'm going to be able to make, because you don't want to say no to the same person like 5 times in a row. At least I don't. If you go online and you can see all the options, then you can quickly pick the one that really truly is the best for you. And so what we have seen is the no-show rate has gone way down. It's, I think, twofold. I think one is people are not saying that they can do something that they really can't do or are not sure if they can do. And the second one is I think they can see sort of the scarcity of appointments sometimes in some specialties. We don't have a lot of appointments, and so if they can see there's only this many appointments available and they pick the one that works best for them, they know that if they don't make that appointment, it's going to be really hard to find something else. And so sometimes they'll keep an appointment, I think, for that. Our clinics with self-scheduling actually maintained better staffing during this whole time. They had lower vacancy rates. I think it's an employee satisfier. Much shorter wait times on the phones, right? The other thing is that our clinic call center is only open during the weekdays. Now patients can schedule anytime they want through MyChart. They can schedule in the middle of the night if they want to. We've had better patient experience scores. Our call abandonment rate went from 17%, that's kind of embarrassingly high, to 2%, much better. Less upset patients, right? One thing that when I talked to the folks at Evergreen Health about this, they said it's really important that you have enough availability in order for it to be successful, right? So if you have lots of patients that are interested in self-scheduling and you don't have enough appointments available, it's not going to work. So that's obvious. And then automated wait list, we have had 9,500 visits scheduled with our automated wait list. It fills automatically late cancellations, right? Reduces fluctuations for our providers, which is a big satisfier for them. And it's a patient satisfier. We think, I don't know this for sure, but we think that if you call a patient, the system, I guess it doesn't call them, but if the system lets you know, oh, someone just canceled an appointment, this is available, are you interested, you're on the wait list, even if they can't take that appointment, it's a satisfier for the patient that you thought of them and that they had the option. And so we're really seeing positive patient experience scores because of that. It moved our patients forward an average of 19 days by putting in an automated wait list. And then virtual visits, obviously you need a little less staff for virtual visits, right? You might not have a PSR for every provider. You don't have to have an MA for that visit. We have a 6 to 7% no-show rate across our whole medical group. It's half that for virtual visits. And it makes sense because people don't run into unexpected traffic or have childcare issues or miss a bus, or, there's less reasons for them to cancel, and so you get less cancellations. Overall, we feel like all of these things that we have been able to do have increased our employee engagement, it's increased our patient experience. We haven't done significant layoffs or anything because of this. We had a lot of vacancies, obviously, and our vacancy rate's gone down. But we have been able to allow our staff to do more proactive outbound calls and work on patient referrals and work on follow-ups and work on annual wellness visits. And so they're able to do other work and get it done and do it well, and it's a satisfier for them and the patients. So, but it could potentially reduce your staff depending on how the organization handles it. So here's the key takeaways. These are not rocket science, obviously. Managing labor expenses is crucial for financial stability. All the things we talked about in the first half can really drive up labor expenses. And hopefully, all the things we talked about in the second half can try to help to mitigate those circumstances. So I'm sure I didn't say anything that really shocked any of you, but I hope there were little tidbits that maybe you could take back to your organizations. I am happy to talk to anyone if you have HR staff in your organizations that might have questions about any of these strategies and you want to connect them with me. I'm more than happy to do that. If you want to reach out, please don't hesitate. But I am also available for any questions.
Quick question on breaks and meals. Can you talk a little bit about the strategies your team has implemented to ensure compliance, given that
Yes.
sometimes adding break nurses doesn't necessarily translate to higher compliance with taking breaks?
Yes, yeah, thank you. That was a very good point. It actually dawns on me now that you say that it's kind of surprising I didn't put anything in here about that, because that's obviously a huge factor in labor expense. We just finished our nursing contract, as I said. We put language in our contract that we would add break nurses, which we've never done before. But the language we put in is, it's very broad, which can be good and can be bad. It says that we basically, as leaders, have the authority and discretion to determine, and we'll do what's reasonable for patient care. That's great because it isn't a commitment. We didn't say we're going to add 25 break nurses, but it's also bad because I anticipate for the next 3 years we're going to battle whether what we did was reasonable and whether the staffing was safe and whether it was appropriate. And so, I don't know what's right or wrong there. I have heard from places that have put in their contracts that they will add a certain number of break nurses, that it is almost impossible to hire nurses who will only do breaks. It's a terrible job. Nobody wants to do it. You come onto a floor, you just break different nurses and their full patient load in 15-minute, 30-minute increments all throughout the day. I wouldn't want to do it. So what I have heard most people are doing instead is saying, on this unit, there is a break assignment of our regular nurses who work on that unit. Somebody will be in that break assignment today, and you will break today, but you are not a break nurse whose full-time job is just to go break nurses every day. I think that's more beneficial. But you're absolutely right. Adding break nurses does not necessarily reduce the number of missed rest breaks and missed meal periods. We all have to report now to the state and our compliance on that. I think if you asked our CNO what is the number one thing that keeps you up at night, she would say the rest break meal period stuff, the hospital staffing committee stuff. It's just the laws are very difficult to comply with, and they're new, and nobody knows how to administer them. And the Washington State Hospital Association has been a really great resource for us on what forms should you use to track that, what do you need to put into your report to DOH on your staffing plan, all that kind of stuff. So I don't have a perfect solution for it, but it's a very, very significant factor. So I'm glad you brought it up. Thank you. Yeah.
Jessica, question around the turnover aspect of that. I'm curious, so coming out of COVID or going into COVID, we saw onboarding really go virtual and in some cases non-existent. Do you all invest in onboarding? Is it in person? How much importance do you put on that?
Yeah, so we didn't shut down at Evergreen Health as much as some places did. I think it really depended on the organization. We didn't close our HR department. They stayed open the whole time through. We have staff, obviously, that work remote, hybrid. So the whole department's not in there like they used to be, but that we stayed open. We kept our new employee orientation in person the whole time. We never went virtual for our training. We right now are not requiring masking in our organization except for obviously the direct patient care treatments and procedures that would require it. But we are requiring masking in our new employee orientation because we have had a number of situations where somebody comes to orientation and then the next day they tell us, oh, I tested positive for COVID, and we had 50 people in that room sitting all close together. So, part of that I think is that someone's about to start a job and they have some symptoms and they don't want to call in sick on their very first day of orientation. So they're like, I'm just going to go, and then they're going to test the next day and tell us. That's gone down a little bit, but we did have a period of time where that kept happening, and so people are masking during orientation. So there definitely would be some value to having an online orientation, but we never did that model. So we're still investing a lot in in-person resource for onboarding and orientation, both for the hospital orientation and the EPIC training, but also the individual department training that people go through once they hit the floors.
Hi. Can you hear me?
I can hear you fine even without it.
Perfect. For your retention for the Diversity, Equity, Inclusion, and Accessibility Council, I'm just curious if you could give a little bit more on that. Is it employee-led? Is it a partnership? We actually just finished labor relations, and that was something that the union really wanted in our contract, and we fought it and we won. It did not go in our contract, but I'm just curious how that is run.
Yeah, great question. So it used to be the Diversity, Equity, Inclusion Council. We just added accessibility not that long ago, DEIA, and it is co-executive sponsored by myself and another one of our executives, but it is chaired by two leaders in the organization, I think they're director level, and the members are from two different sort of buckets. There are certain roles that are assigned to the council. So there is someone there from marketing and communications. There's someone there from patient relations. We have certain positions that we have said there will always be a representative on the committee. And then the rest of it is staff who actually have applied. So we had people fill out an application and say why they have an interest in it, what they think they would bring, do they identify as any underrepresented group, that kind of thing. And the first time we did it, we got, I don't know, way, way, way more applications than we possibly could accept. And so we blinded them, and the committee went through them, and we tried to pick, different divisions and different roles and different representation of groups and, do this perfect algorithm. We got a great group, and then as people have dropped off, we've opened it up again for people to apply, but the number of applications we've gotten has gone down, so it's a little more manageable now. It's a super engaged group. Every meeting, we put way too much on the agenda because, as you can imagine, you get a diverse group like that with different opinions, and they're very passionate about things. Everything you talk about takes forever to talk about, and so we have many, many more initiatives than we're able to get to, but we're making great progress, and it's one of my favorite committees that I get to attend because it's just such a group that cares so much about the employees and the patients, and it's been really great. I'd be happy to talk with anybody about it more if you want to. Yeah. All right, there's a giant timer in the back of the room that says I have 40 more seconds. Okay.
This is great, but you'd mentioned about the recruitment and retention, and that's a very challenging environment for a lot of healthcare.
Yes.
Especially for clinical and non-clinical. So as you guys go to the hospital, these incubators you're trying to set up at the high school and the college level, what message are you trying to, just what message are you giving out so you're trying to create that interest that there is career in non-clinical? Because when you say medical, everyone's thinking clinical.
Yeah, true.
But on the non-clinical and the clinical side, how are you offering extended education if they come on board further their career so they have some type of loyalty with Evergreen to continue on. Because that's the thing, is that there's some success stories in healthcare where some people don't need a higher education, have a successful career in healthcare. But there's two sides of the fence, non-clinical and clinical, and how are you managed to recruit potential, employees in certain areas that need to be filled?
Yeah, no, great question. So we have not done a lot yet with the high school, college age. We did, our Monroe Hospital went to a local event that was put on where they were bringing in employers from the whole region to talk about different healthcare careers with high school students. It was, I think, kind of STEM focused. And what our hospital did was a presentation that showed a patient comes into the emergency department, they go to imaging, they go to surgery, they go to recovery, and for each one of those, they talked about the different types of careers in the hospital that would care for that patient. So they were trying to come up with a theme that could tie it all together, and it was a way they could talk about imaging, and they could talk about nursing, and they could talk about physical therapy or speech or, all the different things. And so they fit as many careers in there as they could. I don't know that they got too much into many of the non-clinical areas, but we could, we could say, and then the patient gets their bill, and this is what happens. I think we could really expand it a lot of different ways. I do think that when you tell someone you work at a hospital, they a lot of times people will ask me, oh, are you a nurse? It's like they think nurses and doctors are the only ones that work at hospitals. So we do have to do a better job communicating all the many. We have, one of the things we complain about in HR is that we have like 300 different job codes or something. There's so many different roles in the hospital. Yeah, great question. Thanks. All right, now I'm over.
Awesome. Round of applause. Thank you.